I hope you all enjoyed lunch and got to connect with each other and maybe with some of our sponsors in the exhibit hall. I know it's hard to come back into a dark room after being outside maybe in the sunshine, but I'm so glad that you did, because this is a great session we have ahead of us. Therapies to preserve and protect muscle. And as I'm sure all of you know, protecting muscle in Duchenne and Becker muscular dystrophy is really important. And the nice thing about the talks we're going to hear, there's been a lot of exciting developments over the past year with 2 new approvals since the last Futures Conference that we had. And the other really wonderful thing about these approaches is they're not applicable to just subsets of Duchenne or Becker. So it's not dependent on which mutation you have, because I know sometimes that makes some families feel left out of opportunities. And then the last thing I'll note, which is really exciting, is that a lot of these therapies can be used in different combinations, either together from some of the speakers you'll hear today, or with some of the other therapies you're going to hear in the other talks. So with that, I'd like to welcome all of my colleagues to the stage so we can get started. So I think if we just pull up the first presentation, we'll get started with Jonathan. Maybe you can try. Do you have the clicker?
That'll work. All right. So it's great to be here with everybody. I'm really excited to discuss the body of evidence for Emflaza in maintaining physical function in boys with DMD. I'm just going to move over to this side of the stage where I have a better view of the screen, and I travel with a laser pointer. Let's see if it'll work. Not really in this cavernous room. In any event, I am Jonathan Blaze. I am a senior medical science liaison at PTC Therapeutics, and I'd love to really begin by restating, right, and underscoring the importance of corticosteroids and the role of corticosteroids in the Duchenne treatment journey. I don't need to belabor to this audience that DMD is a progressive condition, a lifelong condition, with symptoms that manifest in infancy and worsen through adolescence and certainly through adulthood. And these symptoms manifest in a variety of ways, but early on through muscle weakness and loss of function, and then evolving into a more serious deterioration of cardiac and respiratory health. Now, corticosteroids are effective because they reduce inflammation in the muscles of boys living with DMD. And it's this reduction of inflammation and the real interruption of the unrelenting inflammatory and fibrotic replacement cycle that enables corticosteroids to preserve muscle strength and muscle function in the short term, which translates to better functional outcomes in the long term. And that's seen through prolongation of ambulation, the reduced need for scoliosis surgery and surgical intervention elsewhere, and certainly preservation of lung and cardiac function. Now, in DMD, time is muscle. That's a phrase that you'll hear frequently in this community, and it's appropriate. The preservation of muscle is a cornerstone of any effective therapy, and is certainly a cornerstone of slowing disease progression, full stop. The care considerations guidelines in 2018 were updated, stressing the importance of early initiation of corticosteroids right around the time of diagnosis, really to preserve as much functional muscle as possible, in addition to recommendation of continuing corticosteroid use throughout the disease continuum, and certainly after the loss of ambulation, because we're learning more about how steroids preserve and protect the heart and lungs. I speak for everyone at PTC when I say that we welcome any emerging therapy that promises to improve patient outcomes and improve quality of life for patients and caregivers, to reduce burden, and certainly that alters the trajectory of natural history. Until recently, there were only 2 real corticosteroids that were available for treatment of individuals with Duchenne muscular dystrophy, prednisone and Emflaza. And over the last 20 years, there has been a growing body of evidence speaking to the benefits of Emflaza when compared to prednisone, both with regards to safety and efficacy. Now, when you have conversations with your healthcare providers and you're deciding which therapy is best for you, it's important that you recognize and speak to and ask questions about the totality of evidence that exists for any therapy that you're considering, or lack of evidence that exists for a particular therapy. And you want to speak to it in a comprehensive way that captures not only the benefits, but also the side effects. And to that end, we always encourage families to be familiar with and aware of the important safety information. This is the ISI for Emflaza. It's found easily through the FDA's website. It's also found on the prescribing information on the label that can be found on PTC's website, and it communicates important information about warnings with treatment here for Emflaza, but also about side effects that were reported throughout the pivotal clinical trials. Again, we hope that you are well informed and prepared to have these conversations with your healthcare provider when you're considering treatment. Now, for those who are unaware, Emflaza was the first corticosteroid approved in the United States for treatment of individuals with Duchenne muscular dystrophy, and the label was updated to include patients ages 2 and older. So I'll say that again, Emflaza is indicated for individuals with Duchenne muscular dystrophy ages 2 and older. And its approval came after the publication of data from a phase 3 placebo-controlled randomized pivotal clinical trial whereby 196 boys with DMD ages 5 through 15 on Emflaza demonstrated a statistically significant preservation of muscle strength after 12 weeks when compared to the placebo group. That was very important for demonstrating the impact in the short term. But what's not shown in this slide was that there was also a statistically significant preservation of muscle strength amongst the Emflaza-treated boys at 52 weeks when compared to prednisone. And that distinction in therapeutic effect is important and is only seen after long-term data collection, which underscores the limitations of clinical trials and reinforces the importance of collection of real-world data. And I'm going to share a couple of those studies with you now. The first was published in 2018, the Synergy study, which was the largest prospective observational Duchenne natural history study. Featured more than 260 participants, boys and young men with DMD ages 2 to 28, who were evaluated for over 10 years across 20 centers in 9 different countries. And this study, like all studies, of course, has its limitations, but the outcomes were clear. Individuals who were significant and clinically meaningful preservation of functional ability across 3 endpoints. The first was a 2-year delay in the time at which they lost the ability to rise from a supine position. It's a milestone that's typically reached early in the disease course. The second was a nearly 3-year delay in the time to loss of ambulation. The loss of ambulation is a very important functional milestone that is associated with disease severity and disease progression. And again, use of Emflaza when compared to prednisone delayed the time to which boys lost the ability to ambulate by nearly 3 years. And finally, was a nearly 3-year delay in the time to loss of hand-to-mouth function. Now, loss of hand-to-mouth function is typically seen towards the latter stages of the disease course and is intimately associated with patient and caregiver quality of life and independence. And to have that delay in the time to these functional milestones underscores the benefit of Emflaza, not just early in the disease course, not just early initiation, but continued use of Emflaza across the continuum of disease. Next study is the Cincinnati Children's Hospital study, a single retrospective electronic health chart analysis, 435 boys and young men with DMD up to age 25 who were followed for up to 11 years. And the results of this study show a statistically significant preservation of respiratory function as measured by forced vital capacity, in addition to a reduced risk of scoliosis onset compared to those on prednisone. Again, 2 endpoints that are typically in the Emflaza group. Emflaza has a well-established safety profile that's been observed over 20 years of research with more than 14 published studies and over 2,000 patients who have participated. In the pivotal trial I mentioned earlier, There were fewer reports of adverse events in the Emflaza group when compared to the prednisone group, and this is particularly important around behavioral side effects and weight gain. Boys on Emflaza gain less weight than those do on prednisone, but it's also important to say that those on Emflaza did have a frequency to develop cataracts more often. While this is considered a non-serious adverse event, it's certainly something that's worth mentioning and discussing with your healthcare provider. I am quickly running out of time, so I will advance, if I can, to the summary. There is a large form of improved muscle strength, delay in time to loss of functional milestones, improvement of cardiac function, which wasn't discussed here, lung function, and it appears to be more tolerable than prednisone with a gentler safety profile. Before I leave, I would by Duchenne, regardless of their stage within the Duchenne treatment journey. Its support comes in the form of benefits investigations, help with prior authorization, initiation of treatment, help with refills, and certainly bringing folks back to Emflaza who may have stopped treatment for whatever reason. This is a white glove service that is both fortified and cultivated by PTC's commitment to the Duchenne community and our time in the rare disease space. I really appreciate your time, and I look forward to connecting with you over the next couple of days. Thank you.
Thank you for the opportunity here to talk to this audience about Agamree, the newest steroid that's out on the blocks. I'm Stanley Ayochan at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. So I'm going to give you a brief overview of Agamree today. So it is, as I mentioned, it's a new corticosteroid that's available for the treatment of Duchenne muscular dystrophy in patients of age 2 years or older. So as I mentioned, corticosteroids used in Duchenne muscular dystrophy treatment from certain undesirable side effects. So if you look at it closely from a molecular mechanism, Agamree was developed to retain the potent anti-inflammatory effects that are mediated by NF-kappa B mediated pathways, but reduce certain side effects that are related to glucocorticoid response elements. So how is it administered? It is given one time daily. It is an oral solution. It is orange flavored. It's given preferably with a meal. It's stored in a bottle. It's shaken, withdrawn, the exact amount that's for use, administered directly into the mouth, and then the rest of it is refrigerated back in storage. So the pivotal clinical trial that was performed was for 24-week in duration. It was performed on 121 boys with Duchenne muscular dystrophy of ages between 4 and less than 7. It had 4 distinct arms: placebo, prednisone, which was considered the standard of care, with 2 doses of Agamree that was tested, 2 milligram per kilogram per day and 6 milligram per kilogram per day. As you can see, roughly 30 boys were assigned to each of these groups. The primary measurement was based on time to stand velocities, as was pre-specified endpoint. It is the measure of a time that's required for a patient lying down on the ground to get up and to come into a stand-up posture. As you can see, both doses of Agamree at 2 milligram per kilogram per day or 6 milligram per kilogram per day gave an improvement in 0.045 rises per second, and a clinical difference of 0.02 or greater is meaningful in this setting. In addition, a 6-minute walk test was performed as additional measures to look at efficacy, and patients treated with both the doses of Agamree walked much farther than what was done with placebo. On a similar token, time to run/walk 10 meters, TTRW, speed was faster for patients taking Agamree versus placebo as well. In summary, the 24-week period of clinical trial that included the placebo shows the following side effects in patients at least 5% or more treated with Agamree in comparison to placebo. As listed, Cushingoid features, psychiatric disorders, vomiting, weight increase, vitamin E deficiency, cough, headache, diarrhea, increased appetite, and rhinitis were noted. Some of these have been noted in other similar trials as well. So Agamree treatment was compared with prednisone on certain safety measures within this placebo-controlled period. Growth was measured at 24 weeks of treatment, and boys with both the doses of Agamree treatment showed an increased height percentile compared with the decreased height percentile in treatment with prednisone. And Agamree was not associated with the reduction of biological markers of bone health as measured by molecular means in comparison to prednisone treatment. The behavioral treatment was performed in a PARS-3 scoring system, and Agamree treatment was associated with less behavioral problems compared with prednisone over 24 weeks of placebo-based testing. So what are the safety components, information that I need to know about Agamree? It has an increased risk of infection when taking corticosteroids like Agamree. That includes the other corticosteroids as well. Corticosteroids, again, like Agamree, can increase the blood pressure and water retention. Corticosteroids as a blanket, including Agamree, can cause severe behavioral and mood changes. And there is a risk of osteoporosis, and a prolonged use of corticosteroids can lead to bone thinning and long and vertebral bone fractures. Cataracts and glaucoma can be one of the side effects of corticosteroids in general, including Agamree. And rare instances of severe allergic reactions to components in patients receiving corticosteroid therapy has also been noted, and that should be kept in mind. So before starting Agamree, one would be expected to tell all the medical conditions that underlie the patient and date according to immunization guidelines, and live attenuated or live vaccine should be administered at least 4 to 6 weeks prior to initiating Agamree. And at any point, Agamree treatment should not be stopped, or the amount of dose should be changed without consulting with their healthcare provider. Last but not the least, we as Catalyst, we are heavily interested in looking at the long-term benefits and side effects of this medication, and we have established a registry called the SUMMIT study to better document the long-term effects of Agamree treatment. So SUMMIT study will have about 25 trial sites in the United States to look at long-term side effects upon treatment. We do have state-of-the-art imaging studies, part of the study, with travel paid for patients who would be involved in the study, and we are happy to discuss anything regarding the study. I'd be happy to talk to them.
We're not going to, go ahead.
I have one question. Does this particular drug, is it affected by how much salt you take? Like, for example, you said it has no cushingoid features. Does that mean that they are not limited on the amount of salt that they should intake?
I did not mention it did not have cushingoid features, but we do not know the relationship of salt and water retention to this drug quite yet. Based on the preclinical studies, no effect.
Thank you so much. We're going to try to keep to time, so I apologize for we're not going to do question and answer, but all of these companies are here today. There's tables in the exhibitor hall, because we do want you to be able to ask your questions and get some individual feedback. So we'll do that rather than in this session privately. So thank you.
All right, good afternoon, everybody. On behalf of my colleagues at ITF Therapeutics, I want to thank you for giving us the opportunity at ITF Therapeutics, and I want to make sure that you're all aware that I am an employee of ITF Therapeutics. So over the next 8 minutes, I have 2 important topics that I want to go through. The first is, how do we think Duvastat or Duvastat works in Duchenne? The second is to walk through high-level data of the pivotal phase 3 EPIDUS clinical study in Duchenne. But I do want to re-highlight for those of you that Duvastat is an HDAC inhibitor. It's indicated for the treatment of Duchenne muscular dystrophy in individuals who are 6 years of age or older. And so Duvastat really is a first-of-its-kind non-steroidal treatment option for individuals regardless of their genetic mutation. So let's get into the question of how Duvastat or Duvastat might work in Duchenne. And so we know that dystrophin, when it's lacking or not working properly, that ultimately results in muscle fiber injury. However, we also know that that lack of dystrophin can result in inflammation, the impairment of muscle regeneration, and ultimately the formation of scars and fat tissue where muscle would be. So it's a really complex cellular cascade. What I want us to focus on is at the bottom of this chart here, is there's this protein called HDAC. And HDAC is really an overdrive when we're lacking functional dystrophin. So the thought here with Duvastat is, can we reduce the activity of HDAC to help improve outcomes or have a beneficial effect? And so we have studies in animal models of Duchenne and early clinical studies in individuals living with Duchenne that show that administration of Duvastat results in a decrease in inflammatory pathways. You see regeneration of muscle, and in turn, you actually are replacing that muscle or the scarring and the fat tissue with that muscle. So that leads us to say, well, what happens with muscle weakness? And then more importantly, clinically, what should we expect to see with the administration of Duvastat? That will get us into our second topic, which really is to go over the pivotal phase 3 EPIDUS clinical trial. And so the effect and safety of Duvastat for the treatment of Duchenne was evaluated in a randomized, double-blind, placebo-controlled study. It was 18 months in duration. Overall, 179 individuals with a confirmed diagnosis of Duchenne were randomized. So 66% of individuals received Duvastat, whereas the rest received placebo. This was orally administered twice a day. And some more details about the actual study itself is that individuals had to be at least 6 years of age. What you'll see here is that the age ranged from 6 to 15 years old, and the mean age of the study population was about 9.8 years. In addition, individuals needed to be ambulatory, so we assessed this in 2 different ways. First, individuals needed to climb 4 stairs within 8 seconds, and they also needed to rise from the floor within 10 seconds. And then finally, individuals needed to be on a stable dosage of steroids and maintain that throughout the course of the study. So turning to the results, the primary efficacy endpoint of the study was change from baseline to month 18 on the 4-stair climb test, and that was taking Duvastat compared to placebo. And if you look at the table here, what you can see is that the individuals who were in the Duvastat group, they experienced less worsening on the 4-stair climb compared to placebo. And what does that mean with respect to time? There was a change of about 1.8 seconds, or a 40% less worsening on the primary efficacy endpoint. So in addition to meeting the primary efficacy endpoint, we saw consistent effects on key secondary endpoints. So for example, on the North Star ambulatory assessment, what we can see again is that there was less worsening in this endpoint compared to placebo. This was nominally but not statistically significant. So moving to safety, I want to highlight the key adverse events that we saw that were over 5% in individuals that were treated with Duvastat compared to placebo. I'll go start off the top of the list, and that are diarrhea, abdominal pain, thrombocytopenia, nausea, vomiting, high triglycerides, and fever. So a couple of points here. First, most of these adverse events were mild to moderate in severity. Second, 2% of individuals discontinued the study due to adverse events. And then finally, treatment interruption, temporary treatment interruption, or in subsequent dose reduction, it proved useful for the management of adverse events for the individuals that were enrolled in the study. So important safety information that I would like to go over is that Duvastat is associated with low platelet counts in your blood. There's increased levels of fat in your blood, and there's potential frequent loose stools or diarrhea and vomiting. These will be monitored throughout the course of your treatment with Duvastat. Before taking Duvastat, please tell your healthcare provider if you have any heart problems or taking any medicines that could increase your chance for irregular heart rhythms or have any bleeding problems. And then finally, Duvastat can cause serious side effects, so changes in electrical activity of your heart called QT prolongation. And finally, I wanted to leave you with a coming soon, which we're very excited about here. We're going to have an announcement mid-June. There's going to be an update on product availability timing, and also we are going to be introducing the patient support program for patients who are on Duvastat. Please come visit our booth. We are very excited to be here and looking forward to a great conference. Thank you.
Good afternoon, everybody. My name is Mark Awadala. I am with Capricor Therapeutics. Just like to thank Cure Duchenne's for allowing us to come present our 24-month open-label safety and efficacy data on CAP-1002. So this is probably my favorite slide here. It's for all the lawyers in the room. So just a little bit of background of CAP-1002. I've heard, CAP-1002 or the company that's developing a stem cell therapy. I just want to kind of explain a little bit about CAP-1002 and its origin. CAP-1002 is not a stem cell by any means. It's a cellular therapy. It's not a gene therapy. It's not an exon skipper. It's not a steroid. It's a new type of therapy that we are studying, and hopefully at some point in time in the near future will get approved for the treatment of Duchenne muscular dystrophy. CAP-1002 is a cell therapy that is developed from donated human hearts, right? We take those hearts and then we make CAP-1002. CAP-1002 is then infused in patients, and their mechanism of action really is more of an anti-inflammatory, pro-regenerative, and anti-fibrotic mechanism of action that it gets circulated through the body by secreting something called exosomes, which are extracellular vesicles. And these are the things that cells use to kind of communicate between each other. And these exosomes have those properties, and we're seeing a benefit from a safety perspective in patients with DMD in our HOPE-2 studies. CAP-1002 has been infused in over 200 patients, and we have a long-term observation of how it affects patients over the course of 2 years that I'm presenting now, but actually some patients are out to 4 years and they're doing just fine. Our target patient population is the late ambulatory, non-ambulatory setting, which is, we started on the harder scale and we'll then work our way back to see, if it can help patients that are severely affected by this disease. In the HOPE-2, which is the phase 2 double-blind placebo-controlled study, that study read out, I want to say a couple years ago now. It was presented in the Lancet. They had very positive results with our endpoints in the PUL, and back then they were using the PUL 1.2. So in the mid-level PUL, we showed a 71% slowing of disease between placebo and active treated patients. But we also showed a benefit in the stabilization of cardiac with 107% slowing of disease between active and treated patients. From then, after the study read out, there was a little bit of a pause, and that we call that the gap period. And the company then decided, hey, let's have an open label study and invite those patients to come back in. So we invited those patients. 12 out of those 20 patients came back into the study. And here you see some of the results. What you see here in the yellow shaded section is the results using the PUL 2.0. So HOPE-2 measured both PUL 1.2 and PUL 2.0. And PUL 2.0 is now the measure that most everybody's using in this patient population. And in using the total score of the 2.0 in the HOPE-2 study, we did see statistically significant benefits between placebo and active treated patients. In the gap phase, we also looked at the patients before they started the open label, and that gap phase pretty much was about a year. And what it showed to us is that the patients that were on CAP-1002 a year ago had a slower decline than patients that were not on CAP-1002. And you see the different slopes of the lines in the white section there. And then all patients went on to be treated in an open label fashion. And so we see that the disease has then attenuated over the course of the 2 years. Regardless of their original treatment, over the course of 2 years, they lost, on average, 2.8 points over the course of the 2 years, which is, to us, it's indicative of CAP-1002's disease modification potential in patients with DMD. This is a different way to look at our 2-year data. So the dark blue line is patients that were originally treated after the gap. The light blue line were originally treated, right? When we compared it to a 2-year span of non-treatment, there's a significant difference between the two, where there's a difference of just under 5 points between if you were treated versus if you were not treated, which is about a disease attenuation of approximately 64%. We also know that in Duchenne, cardiomyopathy is a problem. It does not get, there's no real improvement within cardiomyopathy, and by early adulthood, all patients with DMT have some sort of clinical manifestation because of the fibrotic implications that happen to the heart over time. With the HOPE-2 OLE, we did not start the trial measuring ejection fraction. However, we did have an ejection fraction measurements of those patients at the end of the original trial. And when we started seeing a benefit in the patients in the open label setting, ventricular ejection fraction for this cardiac MRI, and we saw that 6 out of the 9 patients maintained or improved their cardiac function compared to 3 years ago. 3 patients did decline. When we look at the natural history, so we reached out to Dr. Chet Villa from Cincinnati Children's, and he has a large data set of patients taking cardiac MRIs, and we said, hey, Dr. Villa, let us know what your patients, how they trend over time. And when he analyzed his data, he says that approximately just under 1% of cardiac function loss by left ventricular ejection fraction happens year over year. And when you compare the time frame, you see a different significance of losing about 3 points on your left ventricular ejection fraction compared to an average, essentially, improvement of 2.5 points, as you see here. From a safety perspective, the drug is very well tolerated. We have not seen any grade 3 adverse events associated with the product. We had 1 grade 3 adverse event that was associated with the infusion of the product. There have not been any SAEs that have been attributed to CAP-1002 over the course of up to 24 months, but even thereafter, as I see, and we hope to release the 36-month data actually very soon. We are in a phase 3 setting. We hope to complete the phase 3 pivotal portion by the end of this year, and we are currently working with the agency to hopefully get this drug approved relatively soon. Okay, like everybody says, time is muscle, and we hope that CAP-1002 will prove to be able to preserve both cardiac and skeletal functions over time. And then with that, I'd like to thank Cure Duchenne's, and as they've been a contributor to Capricor, thank you for your support. Definitely all the patients and their families, and all of our esteemed investigators. Thank you.
I like to say they save the best for last, but you'll be the judge of that. So I'm Abby Bronson. I'm from Edgewise Therapeutics, And I'm going to tell you about EDGE 5506 that is now renamed Sevasemten. We like to call it affectionately Seva, and how it works, how we think it might work in muscle, and a little bit about our program. And yes, I have one of these slides as well, and so we're a publicly traded company. I have to put this up. So we are on a mission to discover new medicines that are really going to help people who are facing serious muscle diseases. We were founded in 2017. Our chief scientific officer has a really deep background in muscle biology. Muscle is this huge organ in your body, and so we are developing muscle-targeted therapies for the muscular dystrophies, including Becker and Duchenne. We're the only company that is taking this approach, and we're trying to, we're focused specifically on contraction-induced muscle injury, and we just had a patient counsel and they said, that's so complicated. Why can't you just say injury caused by muscle contraction? So that's the same thing. And what we're developing, Seva, is a daily oral pill. It's once a day. You just take it at night. And I think, as Liana said, it could be used. This is one of those products. Doesn't matter which mutation it is, where it is on the dystrophin gene, in frame, out of frame. It's going to work for everybody, and we hopefully it can be used in combinations with other therapies. So these are clinical trials. We have ongoing trials in Becker and Duchenne. I'm going to talk about them a little bit at the end. But what I wanted to start with is a little bit about how healthy muscle contracts. So you see on the left, and those are a bunch of very tiny muscle fibers, and the blue things between them is where the dystrophin connects to the extracellular matrix, all the stuff that's kind of been in between, and kind of makes a connection to its neighbor. So that, and the bottom shows what happens. Not all those muscle fibers contract at the same time. And you see in the bottom left that there is one in the middle that's contracting. And the connections where the dystrophin is from the inside of that muscle, that fiber to the outside and then connect us to the other ones, it kind of keeps the whole structure in place, kind of like they're springing back and forth. So when you lack dystrophin, on the right-hand side, you can see those little blue connections are not there. So when a muscle fiber contracts, and also there are fast muscle fibers are disproportionately injured, so that one is probably a fast muscle fiber. It's getting injured. And you can see how it contracts. It's not bringing its neighbors along. They're just staying the same, and that's what causes all those muscle tears. So it's a very mechanical way of looking at the disease. And now I'm going to show you that right-hand side actually in a very thin mouse muscle. So on the left is the MDX, so it's a mouse model of Duchenne. On the left is, you can see that it's a contracting, and you can see those little blebs that are starting. Those are those fast muscle fibers, the ones that are more susceptible to injury. They're contracting, they get damaged, those are collapsed, and then enzymes come in, they try to clean up the muscle. On the right-hand side is when we have a little bit of EDGE 5506 or Seva on top, and we just kind of modulate the way that fast muscle fiber is working, and you can see you don't see that damage. So that's the theory that we built our program on. So ARCH, that's the very first human trial we did in Becker, and it's been going on for 24 months now. We just released some 24-month data. And what I'm showing here in Becker is, these are Becker patients, is that normally that orange sloped line on the bottom, we would see from the limited natural history data that we have in Becker that they would experience about a 2.5-point drop in North Star over 2 years. They have been in this trial for 2 years now, and you can see that the North Star score is basically flat or even improved a little bit. So this data has continually given us confidence about moving forward in the other programs and moving forward in Becker and Duchenne. So this is also that 24-month Becker ARCH data, and when those muscles tear, there's unwanted stuff gets leaked out. They usually have a little slide explaining the biomarkers, but there are some biomarkers that you can trace back that are related to muscle damage, and you can see, along with that North Star score, that these 3 measures dropped, and then the drop was sustained over the 24 months. So this also gives us really good confidence about moving forward. So this is the trials that we have ongoing. How many Becker people are in the room? I don't know if there's anybody with Becker. Okay, well, So we do have a pivotal cohort going on, a study that's powered to be able to see differences in treated and non-treated. And then MESA on the bottom is the open label. On the right-hand side is our Duchenne programs, Lynx, Fox, and then Dune is actually it's a kind of a different one altogether. I'm not even going to do that. So these are our trials that we have going on in Duchenne. And you can see on the left side, we're really looking at the whole population and trying to measure the effects of SEVA in each of these populations. So we have cohorts treated with steroids only. We also have patients that have other dystrophin or non-dystrophin therapies, such as exon skipping in the background. We'll take those patients. Then we have a non-steroid treated cohort, and we also have Fox. That is a separate trial, and those are for patients who have been treated with gene therapy. They have to be at least 2 years out from receiving gene therapy, and we have a trial ongoing for that as well. So just in a summary, it's taken orally. I think I said that. We're trying to preserve that injury, that muscle contraction injury, and it's for anybody living with any mutation for Becker and Duchenne. We want to protect those susceptible muscle fibers, and there's a potential for it to be used alone or in combination. So the other thing that we are very focused on is reducing the trial burden for anybody who participates in our trial. So we have engaged with the community. We have patient councils in both Becker and Duchenne. We are trying to gain feedback to understand what are the barriers of participating in trials, and we've really worked hard to reduce those barriers. In fact, the Becker trial only has 7 visits, so we're really listening to what makes a difference in trials. We provide support services for participants to make sure that there's no expense. You should not have an expense for participating in any trial. That's just the way it should work. So we've really worked hard. We do prepaid expenses. We will look at other resources that families need. And the other thing is, if you are in any trial, ask for something. And the worst thing that can happen is a company will say, no, we can't help you there, but it's worth an ask. And we're very, very concerned with the geographical coverage for study sites so that the travel is not that hard. Oops. Oh, sorry. Wait, how do I go backwards? Oops. Let's see if this goes back. I do not know how to go backwards. Okay. There we go. Nope, that's too far. This is not moving forward. It bumps. Okay, you know what? That was a nice picture of a bunch of different patients from Becker and Duchenne. It was my closing slide, and it was just to say thank you. And I want to say thank you to Cure Duchenne for putting this meeting together. They were one of our early funders, so we're really grateful for that support. And I also wanted to mention that we do have a booth, and we do have spots open still in our Lynx trial. So if you are between the ages of 4 and 9, you are ambulatory, and you're interested in what I just showed you, you can come talk to us at our booth as well. So thank you very much.
Let's have another round of applause for all of our speakers. They did a tremendous job. And again, as Abby said, as they all said, they'd love to talk to you. We'll have time this afternoon where people will be at their booths, at their tables. Please seek them out. And we're going to get off the stage because coming up now will be Barry Byrne is going to be moderating a session on multidisciplinary care. And so you're in for some more good content. Thanks.
I sent you your picture. They did save the best for last.
Oh.